2016, 528 billion. So here we are almost a decade later. It's certainly a lot higher. That means we were spending more on non-optimized medications than we spent on any major chronic disease. This is the lowest hanging fruit in healthcare for reducing healthcare spend and reducing patient.
And that's why I've said this before. If PGX testing isn't precision medicine, I don't know what is.
Most providers got little to no genetics education, certainly no pharmacogenetics education when they were going to school. I have been working to advocate for the Right Drug Dose Now Act. This is a federal act that would mandate education for all healthcare providers to educate them on pharmacogenomics and how pharmacogenomics is a tool to reduce adverse drug events. It would also help improve our reporting and tracking system for adverse drug events. On the back end, the FDA adverse event reporting system hasn't been updated since we used cassette tapes as our main way we listened to music.
This is Genetics for Healthcare, a podcast for patients.
Thank you for tuning in to another episode of Genetics for Healthcare, a podcast dedicated to helping patients and their caregivers advocate for a precision medicine approach to treatment, disease screening, and prevention. You can find us on Spotify, YouTube, LinkedIn, Apple Podcasts, Facebook, and Instagram, and maybe TikTok soon. I'm not sure. But either way you find us, hit that subscribe button on YouTube to get alerts and updates on new episodes like this one. Today, we are fortunate to have my good friend in the industry, Kristine Ashcraft, founder and CEO of UScript, to talk to us about pharmacogenomics. Kristine, thank you for being a guest on the podcast.
Thanks so much for inviting me, Rome. Always a pleasure.
It is. Okay, so I got to ask you right off the top, because I hear pharmacogenomics a lot, but also hear pharmacogenetics. Is there a difference? Pharmacogenomics. Help us understand that.
There is a difference, but at this point, they're used interchangeably. Pharmacogenomics is supposed to talk about all of the different genes that impact drug response that you can look at. And pharmacogenetics is more specific, like, let's look at CYP2C19, the gene that helps determine response to Plavix or clopidogrel or citalopram or escitalopram. So it's supposed to be more of a specific targeted type genetic test. Rather than a broad approach to pharmacogenetics, looking at it more comprehensively, but everyone uses it interchangeably. And if you shorten it to PGX, you don't even know whether it's pharmacogenomics or pharmacogenetics, and it's a lot easier to say.
PGX testing, well taken. So I think it's very interesting to hear how you got into the field. On a former podcast that we did, you shared your background, which I didn't know at the time, but I thought it was super interesting that a lot of what we are doing now to find genetic signatures for patients who respond or don't respond to certain therapies or predictive markers started out in the crime field.
Yeah, so I started my career in pharmacogenomics. I was working at Genelex, and Genelex was actually founded in 1987. They were one of the first genetic labs in the country, one of the first crime labs. The co-founder, Howard, actually invented some of the first probes used by the FBI for DNA identification, and that's how he started the company. And when I joined in 2000, they were looking for something that leveraged their core competency in providing really high quality genetic testing. And way back in 2000, there was an article in Fortune magazine about a little boy named Michael who had died of an overdose of Prozac. Like many people, he had a pharmacogenetic variation that made it so that he didn't create an enzyme in his liver called 2D6. This particular enzyme processes about 25% of commonly prescribed medications. So really important one. And he was also taking a lot of other medications. And the combination of those drugs and his genetic makeup led to deadly levels of Prozac in his system. And way back then, the article talked about the dawning of the age of precision medicine when we would use genetic information to be certain we were getting patients the safest and most effective drugs and doses that science allowed for. And even back then, Good science geeks go to PubMed, right? Like, just how common are these variations? Just how many drugs do they impact? And even back in 2000, there were thousands and thousands of publications on just how important this is and how many drugs it impacted. And so we became one of the first CLIA accredited labs in the country to offer that testing.
So I want our listeners to get a better understanding of the difference on how one person metabolizes a drug versus another, and how can you even know that, right? So I think when we talk about precision medicine, it's an industry. It is a term that has been co-opted in a number of things, and I'm certainly not here to define it, but it is leveraging genetic insights to optimize, our healthcare, or in this case, how we metabolize and are affected by our medications. And to me, if that's not precision medicine helping us optimize, the drugs that we take for better outcomes, I don't know what is. But like, how can we better understand this?
Yeah, I'm going to give a simplified version of pharmacogenomics. So most of the time when we take a medication, we take it in an active form. It starts doing whatever our doctor prescribed it for, lowering our blood pressure, reducing our anxiety, whatever it is. And then it hits these enzymes in our liver called cytochromes or CYPs. And our genes dictate how much of these enzymes we can make. Think of this like a highway system. We pretend when we prescribe drugs that everybody has two lanes of these liver highways that process medications. But genetically, some people have one lane, zero lanes, or three or more lanes of these different genetic highways. You get one of those lanes from your mom and one of those lanes from your dad. So sometimes people are like, oh, everybody in my family is sensitive to medications. And that does make sense because that is passed through. But you give these medications, and if you have zero lanes, just like if they shut down the major highway in your city, what happens? Traffic backs up. In this case, the drug backs up in your system. And over time, it can build up to toxic levels. So you start having side effects. Sometimes those side effects can be quite severe. There is a subset of drugs called prodrugs. And these drugs you actually take in an inactive form, and they have to drive on these liver highways, so to speak, to even work. This includes drugs like Plavix. This is a drug that is given after someone has a heart attack or stroke, so they don't have another one. Codeine. Codeine is converted to morphine in our liver. It provides zero pain relief if you have zero lanes of the 2D6 highway that make it provide pain relief. So this subset of drugs you take in an inactive form drives on your liver to actually work these different enzymes. And drugs are very specific. Some only go on one liver enzyme, some go on multiple liver enzymes. And a simple genetic test, a comprehensive panel. UScript is currently part of Arancia that also has Access DX Labs. They do a 37 gene panel that covers medications in pain management, oncology, mental health, GI. So one panel looks at essentially your genetic ability to create these highways that process medication. And when we have that information, just like you go on, Google Maps or whatever you use on your phone to go, hey, I need to get to work today. And it says, oh no, there's a traffic accident on I-5. Here's how you can get to work instead. We can do that with technology. So we take your personal map and then other drugs you need to take and say, hey, that one's not going to work for you. Here's a drug that does the same thing that can take a different highway.
When we think about, things that like the opioid epidemic
Mm-hmm.
in the United States, it would seem that PGX testing would be a screening tool to optimize dosing, because as precision medicine, you want to keep that toxicity down, levels of potential people. You understand the cohort of patients who might be easily more dependent upon that medication, and identify and educate patients about the potential adverse events of dependency.
Yeah.
Is anybody thinking that way with our?
I wish more people thought that way, but back to the example of codeine being converted to morphine. Tramadol is another commonly used pain drug that gets converted to provide any pain relief. There has been a black box warning on codeine and tramadol says, hey, don't give this to kids. Don't give this to nursing mothers, or be very careful. And that's because ultra rapid metabolizers, people with extra lanes of this highway, converted so much to the active form that some children died after simple procedures like tonsillectomies or adenoidectomies, having their tonsils or adenoids removed. And rather than doing a simple genetic test and keeping that information on file, the FDA was like, oh, just stop giving it to this subset of people. But that's not the right way to do it. I think of pharmacogenetics like a safety belt for drugs. You do this once and you put it on every time you get in a car, only in this time the car is anytime a medication decision is being made the rest of your life. We pay for a lot of other preventative screenings, mammograms for breast cancer, colonoscopies for colon cancer. Very important. Like they catch things early and have saved lives. But doing pharmacogenetic panels with a pharmacist review could save far more lives for a fraction of the cost. We currently lose a life every 2 minutes to adverse drug events in this country.
Wow.
It's a fourth leading cause of death.
Eesh. So that's a very powerful. That's a very powerful statistic. I just want to let that breathe, for a minute. What does the data say about the value to patients? I mean, you just quoted that. It's just shocking, just arresting statistic about how patients are dying because they don't have this information. But what is the literature in terms of treatment outcomes and costs say about PGX testing?
Great question. There was a wonderful study that came out of Europe called the PREPARE trial. It was published in Lancet about a year and a half ago, I think now. And this looked at panel testing in several European countries in all sorts of different care settings: cancer care, mental health care, primary care, in pharmacies. And the trigger was just, hey, we're about to give this patient a drug, and there are a lot of them that could be impacted by pharmacogenetic guidance. And so we would recommend a drug or a dose change if they had a certain liver highway variation, so to speak. And in just 12 weeks, they saw a 30% reduction in clinically significant adverse drug events. And that was across all of these different settings. Importantly, in cancer care, and I imagine a lot of your listeners may be battling cancer or caring for somebody that's battling cancer, they didn't count it as a significant adverse event unless it was stage 4 or stage 5. Stage 4 is severe or life-threatening, can hospitalize you, and stage 5 is death. They still saw a greater than 30% reduction in clinically significant adverse drug events in just 12 weeks. I've also personally co-authored studies that have shown dramatic reductions in emergency room visits, hospitalizations, saving $1,100 to over $4,000 per patient, depending on how acute the care setting was, in well under a year.
So over $4,000 cost savings, 30% reductions in adverse events, keeping people out of the hospital, not increasing the cost of care by having to go to the emergency room. I mean, who's responsible for introducing this conversation to patients? I mean, what doctors should be responsible? Because obviously the application of this genetic information can be in any disease.
Yeah. I think that's part of what we've run into in terms of barriers to adoption. This same set of genes, these same liver highways, impact drug response across all sorts of clinical areas. So if a cardiologist orders a test, it has implications for mental health medications and pain medications. And so I think there's been some resistance to the information because of the broad impact. But the ideal healthcare provider to I would say make this part of the standard of care is pharmacists. Pharmacists go to school just as long as medical doctors, and they have 5 times the coursework in pharmacology. They are very well versed to take this on. The issue is, unfortunately, decades ago, they required less education, and federally, they're not recognized as healthcare providers. So a nurse practitioner, PA, has more payment and recognition, even though they have less schooling or training than pharmacists. And that has created some issues with uptake. I think one of the biggest reasons that we have such catastrophic increases in healthcare costs without seeing improvements is the fact that we are not helping that profession practice and get paid at the top of their scope of practice. But those are the specialists, and um, there are instances in which they can be leveraged in more and more states. So, states for at least commercial and Medicaid can say, hey, these should be healthcare providers and we should pay them like other healthcare providers. And that's very much helping. But I would say that people should talk to any of their providers that are giving them medications that are impacted by pharmacogenetics. If you Google CPIC, the Clinical Pharmacogenetics Implementation Consortium, but just CPIC, drug gene, it'll pull up a list of all of the medications that have drug gene interaction guidance. Anything that says A or B, that means there are recommendations to change a drug or a dose if you have pharmacogenetic information. People can go look for their medications there. I'm happy to provide a list of medications by different specialties that you can use to optimize drug and dose selection. But patients should be advocating for themselves. If you can afford it, even if you have to pay out of pocket, talk to a pharmacist. Like, it could save you hospitalization, emergency room visit. The cost differential is very low.
That's why this conversation is important for listeners, I believe, Kristine, because when we're talking about patients on medications and trying to optimize and know for ourselves which medications are going to be best for us,
Mhm.
statistics here, right? So there's 45 million patients, estimated 45 million patients in the US that are taking 5 or more prescription medications. Think about the not just the gene drug interactions, but the drug interactions. And many of those patients are on those medications because they have concomitant illnesses. So you have cancer patients, many cases are on psychotropic drugs, right? So
Mhm.
I think this is just uber important. And to your point, it is critically important that we as individuals know this, know where the information is. We'll post the link to the CPIC website so you can look up your medications. It's a great resource. But also to go in and initiate the conversation with your healthcare provider, if that is your oncologist or your primary care physician, or even your cardiologist, to know this, to even start the conversation. Just kind of a heads up. I mean, maybe you should be the person to tell us. I mean, how are these different specialists now considering PGX testing for their patients as precision medicine grows into these different specialties?
I think we've definitely seen an uptick. There are a lot of positive things happening in pharmacogenomics. So, Medicare issued local coverage determinations in 2020. So, that CPIC list I mentioned, if it's A or B or FDA says it's important, they will cover testing for Medicare patients if the prescriber says, hey, I will change the drug or dose when those results come back if it's indicated for these medications on the list. We can also provide a list of those medications so people can have that conversation with their healthcare providers. I'm on the PGX task force for the American Cancer Society Cancer Action Network, and they have been working on biomarker legislation. And this biomarker legislation is disease agnostic and mandates evidence-based coverage of genetic testing or biomarker testing that has guidelines or LCDs. So it includes pharmacogenetic testing, and that's already passed in 20 states. That means Medicaid, and commercial insurance has to follow suit with this Medicare coverage. And so there's insurance coverage, and there are starting to be lawsuits. So, for example, DPYD for 5-FU or capecitabine. These are very common chemo medications that are given mainly for colorectal cancers, also some breast cancers. And if you have a certain pharmacogenetic variation, your provider is unintentionally doubling the dose of your chemo. which can be avoided with a simple DNA test. And the issue there is patients with these variations given a standard dose, 25.6 times more likely to suffer from treatment-related death. So a woman lost her husband because they didn't even mention this test. It's available. Even if you pay out of pocket, it's just a few $100s. And she lost her husband. It was avoidable. And she sued OHSU and won. She won $1 million, but more importantly, she got them to agree to discuss this testing with every other patient that was going to be exposed to 5-FU or capecitabine going forward, because she didn't want somebody to lose their loved one like she had.
Mhm.
And after that, we saw a dramatic increase in cancer care centers that were like, oh, we should be doing testing. And the vast majority of them aren't just doing a single drug gene pair, they're doing a comprehensive panel. Because to your point, polypharmacy is very common, especially in cancer care. They're not just taking a medication that's a chemo, they're taking a pain medication. Maybe they're taking an antidepressant or anti anxiety. They're taking whatever medications they needed before they were diagnosed with cancer. Their statins, their blood pressure medication, like all of this information. So many drugs are impacted by these PGX variations. So again, a seatbelt that they can use in all of these different areas to optimize drug and dose selection.
Yeah, I like that concept of the seatbelt. I certainly, I certainly want a seatbelt if I'm getting new medications to kind of take it slow and feel protected. On that note, I've heard you speak several times, and you often refer to a study. I think it was 2006 of the U.S. is spending over 528 billion with a B billion on non-optimized medications. And I can't. I'm not sure if I can quote the actual paper.
2016. Yeah,
Okay.
528 billion. So here we are almost a decade later. It's certainly a lot higher. That means we are spending more on non-optimized medications than we spent on any major chronic disease. This is the lowest hanging fruit in healthcare for reducing healthcare spend and reducing patient.
And that's why I've said this before. If PGX testing isn't precision medicine, I don't know what is. Okay. Why do you think providers aren't adopting this more rapidly? And I don't believe, and I've spoken to several physicians, it's not that they're against it whatsoever. I think some of them will readily admit that I don't necessarily know what to do. There's not guidelines on how to do this, but for certain, therapies, there certainly are guidelines. But what is it in the workflow or the attitudes of clinicians? Why aren't they adopting this information more rapidly?
It's a great question. So reimbursement was one barrier, and that is thankfully starting to go away with the Medicare coverage and Medicaid and commercial flowing across. The other big thing is education. Most providers got little to no genetics education, certainly no pharmacogenetics education when they were going to school. I have been working to advocate for the Right Drug Dose Now Act. Swalwell and Crenshaw should reintroduce that this year to Congress. This is a federal act that would mandate education for all healthcare providers, pharmacists, physicians, nurses, PAs, primary care specialists, to educate them on pharmacogenomics and how pharmacogenomics is a tool to reduce adverse drug events. It would also help improve our reporting and tracking system for adverse drug events. On the back end, the FDA adverse event reporting system hasn't been updated since we used cassette tapes as our main way we listened to music. So that's awesome. But a very big piece there. It also looks at clinical decision support. We need to hit the easy button. Everybody knows there's doctor burnout. They're good people. They want to do the right thing. Most people went into healthcare because they want to help their patients, but there's so much they need to keep track of. There's more publications coming out, every day. It's impossible to do it no matter how smart and dedicated you are. And that's where clinical decision support comes in. part of this Right Drug Dose Now Act says, hey, just like we flag for other things in the EHR or pharmacy, we would say, hey, are you about to give Rome Plavix? You need to order a pharmacogenetic test, because without that, you don't know it's not working for him at all. And we don't want him to have another heart attack or stroke. So you can just pop right that up in the EHR or pharmacy software system. And then just like allergies or drug-drug interactions are flagged, once you have that genetic information, you can say, hey, this patient was tested 2 years ago. Don't give a standard dose of citalopram to our friend Rome. That's way too much for him. In fact, we recommend giving him a different antidepressant altogether.
That's
And
good
so
information.
automating that process is part of the Right Drug Dose Now Act. And we're also seeing a lot more health systems investing in that infrastructure to do the
Yeah.
right thing for their patients.
I think that's the tipping point that we need. And we talk about how AI solutions are rapidly coming into, our world in every aspect, but specifically healthcare. Some are a little hesitant. I admit I was kind of one of those. Is like, hold on, right? But if we bit by bit get pieces of AI out there for good use cases like this, remember, Kristine just mentioned that this is a once in a lifetime test. You take it, you will know how you metabolize different drugs as more information comes out about, drugs and how they're metabolized. They get added to necessarily these guidelines, and you will know in your my chart, in your physician or your healthcare system's EHR, if you can imagine the importance of having a conversation with any of your healthcare providers to make sure that's in your record. So no matter where you go, you can have this information. When there are clinicians prescribing new medications, you can have this conversation with the pharmacist who, as busy as they are, if you know your PGX status on certain gene mutations, you can tell them and they can consult with you a little bit more accurately on what you might benefit from or might be harmful for you.
Mm. And I will plug, if you go to fourthcause.org/Right Act, there is more information about the Right Drug Dose Now Act. And please encourage your congressional representatives to co-sponsor that act. It's going to take additional education and technology investments to make medication management safer for everyone. Advocate for yourself. I'm happy to provide a list of the high evidence drug gene interactions by specialty. I'm on LinkedIn, reach out. You can also find me through the UScript website. But these are important conversations. This is one thing a lot of people don't know about. They're like, why would they guess if they could know from the beginning I needed a different drug or half a dose? This is especially important, for antidepressants. People are often given a drug and what do they, come back 6 to 8 weeks, see how you're feeling. We'll maybe adjust your dose. Pharmacogenomics is not a silver bullet that is going to be like, this is the exact drug and dose you need and it'll 100% work from the gate. But what it helps us do is refine that to reduce the number of options available to those that are most likely to work. So why have, 50,000 choices when we know only 5 are likely to work for you?
Absolutely. I don't want to overlook what you said around payer coverage. And what's interesting is there are different healthcare plans out there that say they follow the guidelines or, certain, whether it's NCCN or other guidelines, and they take their direction for testing. And this is a statistic that I got got to call the name, from the Precision Medicine World Conference that said 71% of patients are covered on a health plan that is more restrictive than the guidelines, even though that plan says they refer to the guidelines. Why do you think payers are not incorporating these insights to improve not only, healthcare outcomes, but the cost of care?
To be frank, I think our incentives are disaligned in healthcare. When I first published a study back in 2015 and 2016, the first one showed a 39% reduction in emergency room, or rather hospitalization, 71% reduction in emergency room visits, saved over $1,100 per patient in 4 months. Followed up with a 52% reduction in readmissions, 42% reduction in ER visits, 85% drop in death in 60 days for people post hospitalization. I went into a health system and I said, hey, you should be doing this testing. And we have this great UScript clinical decision support that makes it easy right in your EHR. And they looked at me and they said, it's not that we don't want to do what's best for our patients, but we have this long list of must do's. And you do know the way that we make the most money is emergency room visits and hospitalizations. So what happens if you go to the emergency room or the hospital and now you go to renew your health insurance with your employer and you cost a lot of money? What is the payer going to do? Increase the premiums. Where is the incentive to drive down emergency room visits and hospitalizations? This is why it is so important for patients to advocate for themselves. I would say one of the other issues is CPIC is the guidelines body for pharmacogenomics. This should be the recognized guidelines and just signed off on by all of these other NCCN specialty guidelines. But they don't usually have people, pharmacists being the key, sitting on the committees that are making these decisions. They have very little genetics background. The people making the decisions at the payers usually have very little genetics background. So you have people making decisions with a very limited knowledge set. Really, they ought to rely on the FDA and CPIC guidance.
Absolutely. I was speaking to a group of cancer patients through the Cancer Patient Lab, who I know you've presented to. And a question, it was a very poignant question that I want to share with you. And I'll give you what, my perspective is. But I want to ask you like 3 questions that patients can ask their care providers to start a conversation around PGX testing and advocate for themselves on this genetic information. But the question was, and not necessarily for you to answer this question, but this is the context that we want to deliver, valuable information for our listeners out there who may be going through care, or a family member or someone who is interested in genetics and wants to leverage this information to improve their healthcare, not only for their life, but their family members and generations to come. But the question that the patient asks, and this is real life. Doctor walks in. They probably had 45 seconds to a minute to look over their chart before they came in the room. The question was, what's the likelihood the doctor will incorporate this information? If I bring this to them, it's a 10, 15 page report, right? They just left the other room and probably have some dictation notes on. They're trying to clear their head and come into mind. They're not going to be able to read it, digest the information, especially if they're not familiar with PGX testing. What are some questions that patients can go into these situations, even if they have PGX testing, or in a case where they want it to be ordered, to advocate for themselves, to be considered as a part of their healthcare?
Right. I think that it's important. There's a lot of resources available for people to get some education on pharmacogenomics. We have a little how to talk to your doctor sheet you can download at uscript.com. And it essentially shows, like, are you familiar with pharmacogenomics? Are you familiar with CPIC? There is a guidelines body that says how you can adjust the drugs or doses based on these results. Are you aware that Medicare covers this? Are you aware that Medicaid and commercial now covers it in a growing number of states? Are you incorporating it in the care? If the patient has had a history of treatment failures or adverse effects, that is your body saying, hi, you probably have a PGX variation. Greater than 99% of us have a variation. That on average impacts more than 12 commonly prescribed medications. This is not uncommon. But you may not have been exposed to one of those medications yet. I know I had testing done, and I thankfully didn't have to take medications until I tore my ACL clean in half skiing. And I had this nice drug gene interaction summary that showed the medications where I should avoid them completely, or I may need dosing modification based on my genetic test results. And I brought that into my surgery prep and said, hey, I have these results. I need you to use them to make sure you're giving me the right pain medications and other medications that work for my body. And the doctor was like, I don't understand this. I'm going to grab the pharmacist to talk to you, which was the perfect thing for a doctor to do.
Eureka!
But gratefully, the pain medication that they were going to give me by default was less likely to give me pain relief. So I was incredibly grateful to have that information. But it made it very easy for me to have that conversation. And I think one of the things, do you work with a pharmacist, especially in Medicare, which covers this in all 50 states, right? This is covered for these patients. A lot of people do annual wellness visits for Medicare. And if somebody needs chronic care management, they have a number of conditions. A lot of primary care clinics are starting to bring pharmacists in to do medication optimization as part of the wellness plans for these patients. So, do you collaborate with a pharmacist in your practice? There are billing mechanisms in place to make that work.
I gotta admit that I've been in, oncology care for, I'll just say a long time, tell my age. But the more I have learned about pharmacogenomics, which I guess in context hasn't been that long, it's been the last few years, I have become very passionate about pharmacogenomic testing and creating access for this, creating more awareness, talking to companies in the space who are trying to develop more products that they need to add that. And that's a way that we can, deliver these tests, these products into the point of care where they're needed, because they're companions or complementary to a lot of the other genomic tests that these physicians might be ordering for these patients, especially in oncology or psychiatric care. Or so.
Well,
Thank you
back
for
to, sorry, one back to, I think the easy question, and I do ask this of doctors sometimes. I'm like, what highway do you drive to when you go into the office? What's a big highway in your area, Rome?
Central Expressway in Dallas. Everybody knows that because it's a parking lot most of the day.
Okay. Well, would it be useful to know that the Central Expressway was down to one lane or didn't have any lanes open at all when
Heck
you were
yeah.
planning your commute?
Oh my gosh, yes.
Great. Well, that's exactly what pharmacogenetic testing tells you for the main highways that process medication in your liver. And I would like you to have this information so you're not guessing when you give me medication.
Well, I work I work in the space with, I work in the space with companies that have individual contributor sales teams. And I know a lot of industry folks listen to this podcast. Did you guys just hear that? That's free game for you. Pick up the nuggets and go use that. Love it. Now, before I let you go, did I hear you say you tore your ACL skiing?
I did. I tore it clean in half on Mount Baker.
Well, I went skiing, took my family skiing for the first time in my life. We went to Tahoe, which is beautiful, by the way. It's gorgeous. I didn't know that. And another thing that I found out that I did not know is that if you are a man of a certain age and you've never been on skis before, you need to sit down somewhere, get a drink, look cute, get you some nice, fancy ski equipment or something that you can look fashionable, and stay out of the way before you hurt yourself or somebody. And I'm glad I didn't tear anything. I'm really happy that I didn't tear anything. Oh my gosh.
I think that was me. I used to be, I grew up in Europe and learned how to ski in Austria. And, when you're younger and you think you're immortal and you jump off cliffs and things, I thought I was still that good of a skier when I did it again in my later life. And it turns out you have to do it more often to stay that good.
Listen, my daughter, my 14-year-old daughter, she's the natural athlete of the family, and she got it right away. But our instructor told us, hey, don't go on any runs that you need to take a chairlift to go on, right? Because we took a beginner's class, and she was like, yeah, I want to go. And there was another guy in the class, and he went, and he's like, "That's okay. I fell a few times." I'm like, "Well, if he did it, I can do it." Let me tell you something. I fell so ugly that when I got down that hill, my daughter looked at me and she had a look of horror on her face, and she said, "Daddy, are you okay?" I said, "Of course I'm okay. What are you talking about?" She said, "You sure? That was hard to watch." So needless to say, I'm not going to be skiing. I like my knees. I
Do
like
we have that on video somewhere?
no. Oh no. Oh my gosh. That would be America's Funniest Home Videos. I would win something for those falls.
I'm glad you're okay, because you can get hurt. Yeah.
Indeed you can. So thank you so much, Kristine Ashcraft, CEO and founder of UScript. Thank you for being a guest on Genetics for Healthcare.
Thank you, Rome. Really appreciate it.